Hello, everyone. Happy Thursday. Happy Thursday. Hello, hello. Hello.
Hi.
Oh. Hello. Oops. How are you?
Good. How are you doing?
Good. Happy Thursday.
Happy Thursday.
Welcome back to the Brain PT.
Thanks for having me.
Yay. How's your day going?
Super good. Just
Yeah.
enjoying a good summer day. Kids are in and out with camps, just relaxing, coming back from some good camping. How about you?
So today's a good day because weather in El Paso is so nice. It is quite cloudy and it has been raining, so it's very humid. That's why my hair looks crazy. But we don't get this very often, so it's really nice.
Good, good. Well,
Yeah,
a big
yeah.
congratulations on 2 huge fronts.
Thank you. Thank you. It's super exciting. I cannot believe it. It's like it hasn't, synked in yet. So I'm still like, and my mind is like, I'm still waiting to hear back.
Well, congrats, NCS. That's so exciting.
Thank you. Thank you. It's super exciting. Yeah.
Well,
So now I feel like I have to like, get on it and start reading more evidence, utilize more outcomes, and I feel like more responsibility in me, but that will come with time.
you can take a teeny break if you want.
I
If you want. If not, you just keep charging forward like you do.
I know. Oh my gosh, I know. Well,
And
welcome again.
and
Hello.
congrats on your marriage too. That's a
Oh,
big
thank
one.
you. Yeah, well, we just got the marriage license. We're not married yet until someone signs and all that fun stuff, but everything's coming soon.
Okay, great. Awesome.
Yay! Yeah, so everyone, Dr. Manjiri Dahdul here. Again, she is a neurologic physical therapist. She's the co-founder of Precision Rehabilitation, located in Long Beach, California. And she's awesome. And today she's going to talk to us about locomotor training. And to be honest with you, I am sometimes when I think about locomotor training, I feel like, wow, it's such a broad topic and it scares me a little bit. It's like, oh my God, there's so many things you can do. There's so many devices and like technology and really just the recovery of walking. It's like something that's extremely relevant to us, both to patients and clinicians, and people with a spinal cord injury or someone who lost their ability to walk. Could be a stroke, could be anything. And walking, it's a sign of independence. People want to walk, and 99% of patients will say, I want to walk. I want to walk after a stroke, spinal cord injury, brain injury, anything where you lose your ability to walk. So, and there's so many devices. We have like the Locomat, we have the body weight support treadmill, we have the body weight supported like overground training, which is done, with the harness, overground walking, and the FES, the functional electrical stimulation. So today we're going to talk about, well, Dr. Manjiri will talk about locomotor training and the principles of locomotor training. So the main thing is, how do we start? How do we lose that, like, oh, it's so scary and I don't know how to start. I don't know what to do, like me. And I don't work a lot with people with spinal cord injury, but when I do, it's like, oh, I don't know what to do. So please guide us through this topic and let's learn.
Absolutely. Well, thank you. I know I see patients with spinal cord injury a lot, so it's not as scary, but I'm always trying to make sure I'm on top of the literature. Am I doing the right thing? Am I driving that neuroplasticity and that intensity? And
Yeah.
then there are a lot of different options. So which options are you going to choose? And some of that's limited by what you have in your clinic or in your hospital, but you can always make requests, ask for more. And you'll find today there's actually quite a bit we can do without tons of equipment as well. It's just driving that intensity. So let's go to the basics. Let's not freak out when we see a patient with spinal injury and they want to walk, and that's your main goal, and it's on us. But it's a team effort. It's a team effort between the patient, the therapist, family members, friends. They also play a huge role in all that practice and training at home too. But let's go over a couple of the basics. So start with what you know about the neuroanatomy. We talked about some of this in part 1 a few weeks ago. So I'm going to be citing some spinal injury locomotor training pioneers and gurus. We have to talk about Dr. Andrea Behrman and Dr. Harkema. These are the two big wigs that you go to look for the literature and speak with them sometimes when you can and find out how we can best utilize locomotor training. So the main goal in spinal cord injury with locomotor training, as Harkema and Behrman have stated, is to maximize sensory stimulation to match kinetics, kinematics, and all of these properties are associated with the normal phases of stepping. So what you already know, you got to go back to the basics of gait training. So that's our main goal. And then they highlight 7 key principles. So Lily, you probably know a good chunk of this, but there might be a couple little tweaks.
Okay.
So number 1, stepping velocity. We want to get to normal gait speed, normal stepping velocity. That's principle of locomotor training, number 1. Number 2, we want to try to get as close to normal loading of the limbs and normal phases of gait, loading patterns within those stance phases of gait. Number 3, what you already know, upright trunk and head, right? You're not looking down at your feet. Try to look up and down, or upright most of the time if you can, but if proprioception is lost and there's sensory impairments, you got to look down a little bit. Hip, knee, and ankle kinematics. We want to try to have those as close to the normal range. That's number 4. Number 5, synchronizing that hip extension. So important to get those CPGs activated, synchronizing hip extension as we're going to get that contralateral swing. What were you going to say?
No, CPGs. There it goes again.
Not the clinical practice guidelines this time. This is the central pattern generator. So important that we activate with that hip extension. Okay, number 6. Ooh, this is a tough one, but we've got to do it. We got to aim for it. Avoid upper extremity weight bearing and load bearing as much as possible.
Oh,
I know.
That means like no device, pretty much.
If you can. So obviously that's going to be, well, that depends. That depends what your setup looks like. So on the treadmill, we're going to try to get that reciprocal arm swing. Even it's over ground in a harness of some sort, try to also get that reciprocal arm swing.
Okay.
Now there's a fine balance, right? Because that's going to be hard for a lot of patients. So to me, it's a spectrum. Like that's the goal. We really want to minimize that upper extremity weight bearing so it can come through the trunk, through the pelvis, through the lower extremities. But sometimes that might mean one hand held and the other arm swinging, and then switching, and then the other arm, or NDT pulls. And instead of fully just weight bearing, let's say on a treadmill or some other assistive device, maybe you have assist and you're getting arm swing like this, but forward on an NDT pull. And then I've also done overhead, holding the harness up there to promote that upright trunk and head posture. And even though that's weight bearing, depending on how much you're holding on, at least it's not this forward pitched holding on to the treadmill. So that's a tough one, but so important. Number 7, that was number 6. And then number 7 is maintaining symmetrical kinematics and kinetics associated with the limbs. So those are the 7 key locomotor principles drawn out by Harkema and Behrman that are so important. So that's just the basic. You've got to have that in mind, know that's what you're aiming for and trying to get to in all of your locomotor training. Okay. Does that make you feel relaxed a little bit?
Oh, yes, but oh my gosh, there's so many things that I'm like, oh, I did not know that. And you know, it's great, and like it's like mind-blowing because I'm like, how did I not think about this? And I feel like, and this reminds me of a patient that I had this last couple days, but she when you talked about like not forward flexed and the as close to normal gait velocity and the stance and swing, what do you think about, let's say, so let me give you like a little background. This patient, I was just doing gait training with her. She did not have spinal cord injury, but she had a stroke. So we were starting gait training. So one thing that I have to say for everyone is that once you start teaching gait, it's like you have one shot. You need to teach gait right. So if you just let it just look, because it's not going to look pretty. If you let it not look pretty throughout, it's just going to be negative neuroplasticity. So this patient was really walking not very pretty, okay, very flexed knees with excessive flexion. She was like dragging one foot. And like my internal like neurotherapist was like, I need to stop. Like she cannot walk more because this looks awful. I just need to like go step by step because otherwise her brain will register that as walking and then she will continue to like drag and that. So what do you think about like those times where we really want to push walking and gait training, but obviously the gait doesn't look, close to as a normal gait, but you really want to promote that like stimulus of, the walking, but it just doesn't look pretty. What do you think about that?
Yeah, that is such a predicament that we're always in, right? So
It's
there
like,
is a lot of research showing though, when you push and drive that high velocity, those normal gait patterns are going to naturally work themselves out.
oh, so it would be better to like put her on like a treadmill and just speed it up.
You can do that. I mean, there's so many different factors that involve. I mean, I don't know if there's any contractures or
Right.
spasticity or if cognition or safety is an issue. So you've got to look at all these other comorbidities and issues, but
Mm-hmm.
you can increase the speed and even over ground training, which we're going to talk about today. There's a lot of research showing huge benefits with locomotor training over ground,
Over.
just pushing and challenging your patients over ground,
Mm-hmm.
sometimes pulling the assistive device or even kind of giving them a little assist, like we're going to keep going, or some kind of motivation to get out of their self-selected velocity, get them
Oh.
out of their comfort zone.
Oh. Okay. Oh. Okay.
Even changing the assistive device. I recently, instead of doing a front wheel walker, I used a rollator walker for a patient because it would just make him go faster. And so we had
Mm.
to increase that velocity over ground.
Mm-hmm. Mm-hmm. What do you think about platform walkers?
With the forearm trough walker,
Yeah, the
yeah,
one that
love them.
I know me
Absolutely love them.
because it
Hemi
feels.
walkers.
Oh.
Would you say upright posture? Yeah. Hemi walkers, I mean, I'm pretty opinionated about it. Just throw it in the bonfire. Don't even use it. Even the quad canes, unless it's totally appropriate. I love to train equally with the platform. There's so many different types because you're shifting and getting that weight bearing, not only in the upper extremity, the trunk, the lower extremity. It's just so, so important. It's just selling it to patients and saying, we're not going backwards. We're actually improving your kinematics. We're improving the quality of your gait. And
Yeah.
quite a bit can happen when you bring a platform walker out with the patient. A
Mm-hmm.
lot gets worked out. So I love those.
Yeah. Oh, all right. Well, what about overground training? What do you have to share with us about overground training? Let's say we don't have a treadmill and like
Mhm.
overhead system, and we just have a bunch of assistive devices, walkers, and we just need to do overground. So, what are some things that you think for you it has worked on the clinic through like, training someone with a spinal cord injury with like overground ambulation?
So I love my light gait system. I'm all about body
Oh,
weight supported gait training as much as we can and trying
yeah.
not to unweight individuals as much as possible. But there's a lot you could definitely do over ground, bracing as needed. E-stim
Mm-hmm.
with gait training over ground is huge. I see one of my colleagues on here who does that a lot. I mean, she is like the e-stim queen. I just love how
Wow.
she busts out the device and she is gait training on the treadmill and over ground. with that device, and it's just so important, and the research is showing that. So let's jump into a little bit of that. There's a great study I've got right here, Merowitz and Moffitt in 2013. It was the effects of locomotor training after incomplete SCI. So this was an awesome study looking at all these different types of gait training in spinal injury that you had mentioned. It's a systematic review. So they had 8 RCTs, and they used all different types of interventions. So the first one was body weight support, treadmill training with and without FES. Then there was overground training, same, both with and without FES. And then robotic assisted body weight supported training. So this one showed that with acute spinal injury, so that's less than 1 year after initial onset, improvements were greatest with body weight support, treadmill training, and robotics.
Oh.
Surprisingly, because there's a lot of research showing robotics is not necessarily the best way to go, but we're going to talk about this. There's so many different articles out there, and the evidence is still very limited to say this is one way that you should do it. But this was a great systematic review. So again, for acute injuries, robotics and body weight support, treadmill training showed the greatest improvements. And then for chronic, though, it was very different. It was body weight support, treadmill, and overground, and both of those with FES.
Wow. Oh, wow.
Those showed the most significant improvements in kinematics and locomotor training. Less improvements were noted with body weight support assist, manually assisting, so not with FES.
Oh, okay. So that's the least.
That was less. So I still see the benefit clinically of that as needed, but this research and the systematic review is showing that FES with body weight support treadmill training for chronic SCI is superior to the manual assist or robotics or just conventional therapy. It's an interesting term, conventional therapy.
Yeah. So what do you recommend for those, let's say, clinicians that are working at, in any setting? It could be inpatient rehab, because you will find a lot of patients with spinal cord injury in rehab, that they don't have, let's say, FES system, and they just have like the light gait or the treadmill train with the harness. What would you recommend for them to do? Do they manually assist through the stepping? What is the way to go for them?
You have to use what you have. So if you are only with a body weight support system and no FES, use that, because you're still going to drive those huge, important principles of locomotor training by getting that normal stepping, get the kinematics going, get that velocity. You're in a safer environment that you can maybe try to minimize upper extremities, get upright posture. So you're targeting as many of those 7 principles of locomotor training as you can. And then I would say, you don't have to have a fancy e-stim device. We used to love the EMPI unit, but now it's the Chattanooga. I don't remember exactly which one that is, but it's portable. It's amazing. You can do triggered. So I would say get one of those. I mean, almost any clinic can afford that. We're a small boutique outpatient neuro clinic, and it's worth it. It is absolutely worth it. So stimulate what muscles you want, get a trigger, and bam, you've got e-stim overground and on the body weight support treadmill system, and you don't need something fancy. But I also do like some of those other Bluetooth devices, like the Bioness is great, and they're absolutely willing to come and demo their equipment for you to try with patients. So if you want e-stim, you can get e-stim.
Yeah, and I know there's so many places like El Paso that we don't have a lot of clinics that are like specialized neuro clinics with all like this fancy equipment, like, I don't know, Houston or Dallas. So, I know a lot of PTs that have trouble with that. a lot of us just use like conventional training over ground training. At my rehab, we use a lot of, the platform, and we do have a body weight support system. But I feel like some patients kind of like don't like it. It seems overwhelming to them. So it's more like selling it to them so they can be like, okay, I like this. So I found some barriers in that, especially when I'm trying to do like high intensity, that patients really just like don't like it because we're pushing them, obviously. Um, so yeah, that's my experience with that. But I mean, the evidence is there. It's like, this is what you will have. So yeah, we just need to start educating the therapist on this. So I feel like those principles are super helpful to know where to start. And this applies to all gait training, I feel.
Yeah.
All types of gait training. Yeah.
Absolutely. Now, when you said patients are a little bit resistant, is that to the platform walker?
To the body weight support treadmill.
Oh, to the body weight support. Okay. Interesting.
Mm-hmm. Mm-hmm. Yeah. Yeah. I've had a couple that like they're like, I didn't like it. And I'm like, and I cannot push them. I just need to like talk to them about it and the benefits and things like that. So yeah, I found some patients give me like a little bit of resistance, and maybe it's because of the setting that I'm in, or just the population that I've found. I'm sure this is like, maybe it's just the case here. I don't know. We do get a lot of older people, so they tend to be like, sometimes. So I try not to push them like, okay, let's do it again, because then I need to take care of like the report, I feel, a lot. So when someone is like really willing to do it, I'm like, yes, let's do it again.
Yay!
But yeah, I found one patient that he didn't like it, and I was like, okay, we'll just do over ground.
Yeah, and the research is showing that that can be beneficial too, as long as you're using those principles,
Mm-hmm.
driving neuroplasticity, getting that intensity, its task specificity. A couple things for some patients who don't like the harness or don't want to walk fast on the treadmill. They
Mm-hmm.
also have leg straps instead of the groin strap.
Mm-hmm.
Some harnesses do. And so I've found that that could be helpful. Some people get uncomfortable in the groin straps. I'm like, you know what? We'll just use the leg straps and then not unweight you too much. And
Mm-hmm.
then you know this already, just baby steps. Like maybe we're going to do 5 minutes today and at a slower speed. And then,
Yeah.
ooh, look at you. You're going faster and longer.
Uh-huh.
You're
Yeah.
just their personal cheerleader.
Yes, I know. Uh-huh. What about the speed? Like, how quickly should we go from their baseline, from their walking speed?
So the goal is to get up to normal gait velocity as best as you can.
Mm-hmm.
So in the literature that I looked at with SCI, I don't know that I necessarily saw a specific gait speed, but I know with CVA 2.0 is a
Mm.
great speed to push up to get to. And you
Oh.
can see a lot of good normal kinematics come in at about 2.0, but it's just very dependent on who the patient is and what they can tolerate. But
Mm-hmm.
just building up to that, oftentimes I start at maybe 0.7, 0.8, depending on the patient. And then you just keep pushing. And the goal is to get up to that 2.0 to the best of your ability.
Mm-hmm. Yeah. I remember when I was doing the consortium, there was a locomotor training course, and I remember hearing about how just sometimes cranking the speed up and letting the brain figure it out.
Mm-hmm.
It just sounds like weird, but it's just sometimes the best way to start,
Mm-hmm.
just to see what happens. I remember hearing that and I was like, oh. And then I also remember hearing that with the treadmill, you work on that number of steps. So that's like repetition. So here again, you go back to your principles, even like the principles of neuroplasticity, the repetition matters. Um, so yeah, I mean, I feel like once we know those principles that you mentioned, and even just like read the article that you mentioned, everything will make more sense. Like now I feel like, okay, like right now I'm experiencing some of like, okay, I feel like now I get some with spinal cord injury. I know what to do. I hope everyone feels that way now. Whoever feels like me, like, ooh, yeah. But anything else that you think it's like, oh, you guys need to know this about locomotor training?
That was one of the best articles that I found, that
Yeah.
systematic review by Marowitz and Moffitt. I'm taking a look at a couple of these others to see what's good. I know you threw up some great articles on who's going to walk, a review of
Mhm.
factors.
Yeah.
And so even just looking, I know here we're talking about locomotor training, but even just like that baseline, what was the Asia score at 72 hours post
Hmm.
the initial injury, that can really help determine what things will progress and look like. Although a lot of our complete spinal cord injuries we're finding are really, in fact, incomplete.
Hmm.
60 to 80%. There's those neuronal tracks still connecting. Looking at some of those reflexes, we know specific syndromes with spinal cord injury are going to recover with walking
Hmm.
more quickly and faster and just more likely to recover. So central cord syndrome and Brown-Séquard syndrome, those are usually community ambulators. They have a higher percentage of getting there.
Hmm.
And then even just, did they get that early and high dose of methylprednisolone as well as that surgical decompression, which are both standards of care. So typically that is occurring after spinal injury. And those have shown to have significant improvement in neurological return.
Hmm. This article, it's so great. I read this through my NCS studying when I was doing studying SCI, and it just has awesome information for you guys about what will tell you this patient will most likely be or turn into an incomplete or good prognosis for ambulation. It talks about pinprick preservation, how it's important because it's very close to their, so we remember the pinprick, so pain. So spinal thalamic tracts are very close to your cortical spinal. So that means if they're close and you still have pinprick preservation, then you probably will have some of those preservation of motor movement tracts. So it talks about all this and it's so great. There's also a handout that I made for you guys. If you're interested, I can send it to you. It has all about the cord, the cord syndrome, central, anterior, posterior cord, Brown-Séquard. If you guys are interested, for those who are preparing for NCS next year. But thank you so much. This was so awesome. I feel more confident now that I'm going to look at that article. I can't believe I've never heard about this article. Maybe I was lost somewhere.
Which one?
The one that you said, the pioneers, the principles of
Oh,
I am so impressed that I did not, or maybe I did, I just didn't pay attention because I was so overwhelmed with articles. But I'm so impressed that I didn't read this article through my NCS prep. But now I know.
well,
It's
let's throw it up there for everyone. That's Behrman and Harkema 2000, just some basic but key principles of locomotor training that are really helpful as like the foundation and basics for how am I going to do this?
mm-hmm.
How can I make a
Yeah,
change?
yeah. Well, thank you so much again for awesome knowledge and learning. Thank you so much for coming again. Next time we'll plan something else, spinal cord injury, because this has been awesome and I've learned so much from those two spinal cord injury topics. Thank you guys so much. I hope you all have a wonderful Thursday. Tomorrow we're going to have a video of me reflecting my NCS prep for everyone who is willing to study for this beast. Thank you, Manjiri, so much for coming again. It was so fun. I will reach out to you for maybe more spinal cord topics, and I will see you soon.
All right, have a good one.
You too. Bye.
Bye.
Bye, everyone.